Now let's get back to my interview with the one and only Dr. Anthony Fauci. Your institution, the National Institute of Allergies and Infectious Diseases, recently announced some very exciting results from a study of injectable pre-exposure prophylactics, or PrEP, as it has become very commonly known. What makes that study important, Doc, and what do we hope to see in the next few years?
Well, it's part of a series of studies to take a look at the question, can we have people stay in complete remission, but be ART either free, namely substitute something like a monoclonal antibody or an immune-based therapy. But if not, can you draw out the amount of time that you have to get administered an ART? So we know that there is a thing called pill fatigue. And anybody that denies that, people do not want to be able to have to take a medicine every single day that reminds them that they're living with HIV. Wouldn't it be nice if you could just do it every once in a while? Well, the long
as long as it doesn't hurt too much. I don't want too much pain, Doc.
No, there's not too much pain, I'll guarantee. And we know that from the study. But the study you're referring to is really a good study. It's long-acting cabotegravir. And we feel that with some good chemical manipulation of molecules, that you can get a injectable long-acting antiretroviral to be given at a much longer interval. If we could get it down to 1 every 6 months, that would be wonderful. I mean, to just come into a clinic or even to an outpatient and get an injection once every 6 months, twice a year, and know your viral load will stay undetectable would be absolutely wonderful. And that is doable. That's not just aspirational.
You are also one of the architects of what some are saying is a very ambitious new plan to end the HIV epidemic here in the United States by 2030. With COVID-19 coming in, and I guess this plays a little bit to what we talked about at the top of the interview, how confident are you at achieving these goals by 2030?
You know, I can tell you honestly, I'm cautiously optimistic that we can do that because we're seeing some models in different places, in different cities. Like the San Francisco model is a superb model of that. The New York model, which is copied after the San Francisco model, is actually doing very, very well thus far. I think it is doable. What we're doing is getting out, and this gets back to one of your previous questions, engaging the community, but at a level that it is a feasible engagement. Like I always use the typical, somewhat tongue-in-cheek analogy of saying, you don't want a white guy in a suit like me going into the suburban area of Mississippi and getting African-American gay men to come in and understand how they need to get on PrEP and how do we get them on PrEP if they're at risk, and if they're infected, how do we get them into a program? You've got to go to the outreach. And in the United States, and it could be a model for the rest of the world, we have a very heterogeneous population. I mean, the difference between the New York metropolitan area and rural Alabama is really huge. And you've got to fashion both your access to medication, your prevention therapy, and other trials according to the location and the demographic group. So I believe that since we are aware of that and we're paying attention to how you need to outreach the community, because those are the recalcitrant areas. I think most people know I'll be talking about this at the meeting, is that we have a very large country in the United States. There's 3,007 counties. Most of the infections are in like 50 of those counties, which is in some respects astounding. There are geographic and demographic concentrations. If we can focus our effort on that, then I think we could get to the goal of 75% decrease in 5 years and 90% decrease in 10 years.